Good evening, ma'am.
Good evening.
There are 20 people who are logged in. I think we can start now.
Yeah. They started logging. You be with me, okay?
Okay. The people who are presenting and discussing, they are there.
Yeah, please start. Let's start.
Okay. So good evening, everyone. Welcome to today's clinics. Today the faculty is none other than our beloved ma'am, Jayanti ma'am, who is well known to all of you. She is the professor of hepatology at SRMC, Chennai. Today we have a case with back pain radiating to leg plus jaundice, and this case will be discussed by Dr. Srividya B. Pillai. She is the senior resident in gastroenterology at PPS Lakeshore Hospital, Kochi. Discussed along with her by Dr. Emia from Trippuram, Chennai. Well, Srividya to upload her slides.
Yes, sir.
1 second. I have to stop sharing.
Sir, sir, is it visible? Slide?
Yeah. No, for me, your slides are there. Let me see. Ma'am, is her slides visible? No.
Yeah, it's visible. Go to full screen. Yeah, it's fine. Yeah, it's fine.
Okay, ma'am.
Dr. Vijay, you're with me, no? Dr. Vijay? 1 minute. Dr. Varghese, we can start? Okay, you start.
Good morning, all. Good evening, all. Presenting complaints.
Can we start?
Yeah, we are starting. You'll be with me, huh?
Yes.
Okay.
Yes, ma'am. Can I continue, ma'am?
Yeah, please do.
I am presenting 42-year-old male who is a resident of Ernakulam, now presented with complaints of back pain for 4 months, abdominal pain for 1 month, and yellowish discoloration of urine and skin for 1.5 weeks. History of presenting complaints. Patient was apparently normal till February 2021 when he developed backache. It was mainly in the middle and lower back. History suggestive of lumbar and sacral region. Radiation associated with the radiation of pain to the right leg while walking, and this pain disturbed his sleep and affected his day-to-day activity. For the above complaints, he consulted a local hospital and was managed conservatively. 2 months later, as his pain was not subsiding, he consulted an Ayurvedic doctor and took Kashayam for 1 month. After that, he stopped that Ayurvedic medication. By mid of April 2021, he developed right upper quadrant pain in the abdomen. And it was a dull aching pain, persisted round the clock with no history of any radiation, no relation to food intake, posture, or respiration. Not associated with any vomiting, or it was not relieved, it was not at all associated with vomiting. And it was mildly relieved by pain medication. And for past 1.5 weeks, that is by the May 2021, he noticed yellowish discoloration of the urine and eyes. It was gradually progressing throughout the body, associated with pruritus and clay-colored stools, not associated with any fever, myalgia, or arthralgia, and no history of any associated abdominal distension. He also complains of associated loss of appetite since 3 months, and history of significant weight loss, that is 67 kg to 58 kg in last 3 months. They had a history of maximum dry weight that's 10 years back was 79 kg. And the main major negative history was no history of any abdominal distension or awareness of any abdominal lump, hematemesis or melena, no history of any altered sensorium or altered sleep pattern, or fever, cough, or night sweat, no previous history of previous blood transfusion, tattooing, or high-risk behavior, no history of any night blindness, ecchymosis, irreversibility, bleeding manifestation, numbness, or ataxia, or no history of any joint pain or restriction of joint movements or chronic diarrhea or blood in stools. For the above complaints, he consulted a physician, a local physician, and whom a USG abdomen and CT, plain CT done outside, and he was told to have a liver and bone lesion as referred to a hospital for further management by May 21st, 2021. Ma'am.
Can you expand on the jaundice? No. Okay, continue. We finish the presentation.
Okay, ma'am. Past history of jaundice at he had a history of 2 episodes of jaundice in the childhood. Is 12 years of age, and in 2018, both were managed in the home itself. And he's telling a history of he was tested positive for HBsAg in 2018, and later he was tested and is recorded as negative, and no specific treatment taken. And history of type 2 diabetes mellitus since 2018, controlled on oral hypoglycemic medication. Here's a history of Ayurvedic intake 1 month back. No history of any tuberculosis, coronary artery disease, CV, or gallstone disease. Personal history: appetite reduced, 24-hour recall, 1200 kilocalorie, 30 grams protein, deficient of 18 kilocalorie and 29 gram protein, and no history of any addiction. Family history is both mother and father are alive, and mother is having type 2 diabetes mellitus. Otherwise, all are healthy in the family. No similar illness or any malignancy or tuberculosis in the family. Socioeconomic history: middle class family, Pakka house. He is working as a Panchayat vice president. Modified Cook-Scale skill showing upper middle class. So, ma'am.
Yeah, before you go to the summary,
yes, ma'am.
Can you just expand on the jaundice that he had?
Ma'am, he was having yellowish discoloration of urine and eyes. Initially, he is noticed in the urine and later progressed noticed in the eyes, and then gradually in 1.5 weeks, it progressed throughout the body, associated with pruritus.
It's very difficult, no? A patient to say that it came in the hands and then the feet and the whole body. I think that was too expansive. What I want to know is, one, is it just progressive, no?
Yes, ma'am.
And
ma'am, may I ask a doubt?
Yeah.
Should the candidate say in such great detail it has started in the urine, then started in the pump? It will irritate the examiners, no?
Yeah.
Because for super specialty level, I think you say jaundice and how it evolved.
And the patient will not even know, whether it went to the urine first and then it went there and then it went here and all. Nothing. It just, and I'm sure you don't even take this history in the outpatient, no? We ask the question in the outpatient clinic that we know did it start in the feet? What difference does it make whether it starts in the head or it starts in the body or in the feet?
Okay.
So what is your? Can you just discuss what is it that you're dealing with before you go to the summary?
Ma'am, what, ma'am? I can't understand.
What is it that you're dealing with based on? Can you tell what are you dealing with the presence of that back pain that this patient has?
Yes, ma'am. The patient is having jaundice.
No, pain. Just the pain. Based on the pain, no? Do you think it gives any?
Ma'am, it is a significant pain and it is disturbing his sleep. So it's a bone pain, significant pain.
So what do you think? Where do you think the pathology is? It is a pain that's going to the right side. I just say it is a lumbosacral pain with a radicular pain. So what difference does it make? What else would you ask? What else would you ask to know whether it's significant or not? One is you have to ask, whether it was an acute episode. Was it? Basically, if a person comes, supposing you had seen the patient then, when he came with the back pain, what are the things that would cross your mind? Now he's come to you after jaundice, but what would be your discussion? Had he come to you with the back pain, and you think it was a ureteric colic, and the patient was referred to you as an abdominal pain? What are the things that cross your mind? Based on that pain, based on the pain description that he describes, what are the differentials at that stage here?
It's a radicular pain, the disc prolapse.
Exactly. So it's more of a radicular pain that is radiating to the right lower limb. And then what other questions that you would ask? One is with more posture, whether there's any pain. Whether
Yes,
by
ma'am.
bending, stooping, was there any pain? By coughing or sneezing, would he get a severe pain? So those are the things that will give you a clue once again that it is arising from somewhere in the spinal region and that's going to the back. So
Yes,
any,
ma'am.
you ask the history of trauma, you ask the history of any lifting, any heavy weight. What are the things? Those are the things that you have to question in this patient, and not
Okay.
come to a conclusion based on the finding in the liver and finding in the
Bone.
that the whole thing is related to that. Okay, so
Okay,
what is your summary of that pain? The pain that you described, the dull pain in the back, not
pain.
the abdomen, yeah, the front. The back.
Pain is looking like a radicular, history-wise looking like a sensitive of radicular pain, but it is it's just widespread, ma'am. From the middle and lower back, it is spreading in a larger area.
Lumbosacral. That's what I said. It's lumbosacral, no? It's more of
Yes,
a
ma'am.
lumbosacral pain. It looks more like a radicular pain. So other question that you should ask is this: you want to know whether it's true radicular arising something in the bone, whether it's relation to cough, whether it's relation to sneezing, posture change. All these would make a difference and give us some information what you're dealing with. Okay.
Okay.
Then the next one is, and I think the other, just go back to the slide. Don't mention all this, no? 2 months later, he consulted the Ayurvedic doctor. Just say that he took alternative medicine for this.
Okay, ma'am.
Yeah, because today in India, we are moving towards Ayush, they're moving towards Ayurvedic and all this, and therefore we have no right to negate the utility or the uses of Ayurvedic. So don't mention all that, but you can say alternative system of medicine, which is probably an Ayurvedic medicine.
Okay, ma'am.
Rather than saying that he went to the Ayurvedic doctor and all that, okay? Okay. Then for the above complaints, you can any X-ray or anything was taken for that pain because that pain is almost there for.
According to his history, X-ray was taken and they told it was okay and they were managed conservative. Like that, he told.
But what happened to the pain over the period of time from February to May?
It gradually increased. It gradually increased.
It increased in intensity.
Increased in intensity.
Because the jaundice has come on much later. It has come just for 10 days. No? Yes, jaundice is just for a week to 10 days.
Yes, ma'am. It was gradually increasing over the time.
So what? So you would have gone back to the doctor to find out what it is. So just be careful about that particular history. Then,
the onset was not mentioned in the slide, no? The onset is very important, no?
Yeah.
Oh, yes,
onset, acute onset or insidious onset.
Insidious.
And what was the severity of pain initially, and what was the severity of pain when he presented to you, like that, no? You have already mentioned disturbed sleep. That means it should have been fairly severe pain, even to begin with.
And definitely some person would have done an MRI spine, something, beyond for 2.5 months, a person is suffering with so much pain with the pain in the abdomen, he would have gone to another doctor to just get that information out. I'd be more worried if the pain persists for 2.5 months and he's just managing with the paracetamol or something like that. That will give us some clue, no? What is the event that is taking place along with that over a period of time? I think that is important.
Okay, ma'am.
Let's move on to the next slide. This one, what is your interpretation of this right upper quadrant pain?
Right. Ma'am, in this patient, the pain is in the right upper quadrant. It is a continuous pain.
No, so what do you think it is? Suddenly a person has a back pain, and then he has a pain in the front. And it was lumbosacral.
Radicular pain can be there, ma'am. Radiating pain.
It could be still a radicular pain.
Radicular pain.
Yeah. But then
but it was not exacerbated, ma'am. This was not exacerbated by any posture or any movement. So radicular pain.
So would you like to, at this stage, would you connect that pain? A patient comes to us with OP and he has this back pain for such a long time and then he says, I have a front pain. So what would be their first reaction? No? What are we dealing with?
Radicular pain. First DD is radicular pain.
First would be a radicular pain, yes. Because it's a continuous pain. It's a one direct continuous pain. Okay?
Yes, ma'am.
Another possibility is that he can have a mets in the rib and then it can fracture and produce continuous pain, plus aggravated by respiration, movements, etc. That's also there. Here again, the onset of the pain, its progress is also not described. I think you have to describe the onset of the pain, its severity, and how it evolved over the next couple of weeks until the patient reached, that part of the history should be always mentioned properly.
Okay, sir.
Okay, ma'am.
The other way is you can, I mean, even cut short the whole story and say that patient is being referred to us with history of jaundice with a probable pathology in the bone and the liver bed, as per the discussion of one of the consultants outside. So that so that you're not beating around the bush for this back pain, and then for the pain that's occurring in the right upper quadrant, because we already got a clue there.
Okay.
So if that was
Okay.
the clue, then I think we should just take the lead from there. And because he's come to you for treatment, he's not come to you
Yes,
for
ma'am.
diagnosis.
Yes, ma'am.
He's not come to you for diagnosis of the mets or whatever it is in the bone as well as here.
Okay, ma'am.
No, he's come to you for management of a lesion in the liver. And he says, I have got pathology in the liver and I've got pathology in the spine. And then probably what will be your take if that was the history? The person says that I have a problem in the spine. I've been told that I want to have a problem in the liver. That's what was a disclosure by the doctor. So based
Yes,
on
ma'am.
that, what questions would you ask? That would be the lead,
Yes, ma'am.
And then you say this was in a background of a pain that was there at the back and then in the front. Okay, that you can mention.
Okay,
Okay,
ma'am.
then so then of course the jaundice bit don't mention so much about it progressing
Okay,
from
ma'am.
one portion to the other.
Okay, ma'am. Okay.
So what are the things that cross your mind now? That is pain in the back and from the front, and there's a pathology in the liver, and there's one report of an HbA1c. What's your take on that HbA1c positivity?
Patient in HBS chronic hepatitis patient.
No, you said positive, it became negative. So what's your take on that?
Yes, ma'am. He's telling positive and negative. So in that chronic hepatitis B, chance of chronic hepatitis B is less likely, ma'am.
You say that. What is the chance for spontaneous clear? What are the possibilities that positive has become negative? When all can this happen?
Acute viral hepatitis, more than 90% will be spontaneous resolution.
He's not had acute viral hepatitis, no? There's one jaundice at the age of 12.
And one other episode in 2018, ma'am. In that episode, he was diagnosed to have HbA1c positive.
So that you have to expand.
Yes,
okay, 2018 means 4 years back, no?
Yes, ma'am.
It's a shorter period in the natural history of hepatitis B, chronic hepatitis B, no? So what are the chances of he becoming negative? Unless he had, what was the presentation acute hepatitis in 2018?
I don't think you expanded on that. You made a passing statement. You just
what made him to know that he is HbA1c positive?
Positive, exactly. You just mentioned one statement which is wrong. That this is what requires expansion. 2018.
In 2018, he was a hepatitis episode. He was telling he was fever, myalgia, and prodromal symptoms was there, and jaundice. And for that, he consulted a local physician, and he.
This local physician, don't use the word local. I like a word called family physician. Every patient will have a family physician. Okay,
ma'am.
This local physician, you're actually degrading that physician, no?
Okay, ma'am. Okay.
Or we may be totally wrong as a specialist, and that fellow who's the local physician may be 100% right. So just say, mention he consulted his family physician.
Consulted a family physician, and he tested the blood investigation. In that, HbA1c came positive.
So what would be the presentation of acute hepatitis, acute viral hepatitis due to B, that would say yes, it was B and it became negative? How would you get that history out? Because it's just one single statement, no? 2018, one positive became positive, so just as though there's nothing important to you. So can you just tell what would be that history that will give you a clue that it was a reactivation of hepatitis B? It's possible.
Yes. Because according to some specialists, acute hepatitis B in adults most often is a reactivation.
Reactivation. Dr. Sarin also says that it is never de novo name acute hepatitis B. It's usually 99% of reactivation. And for all you know, he may have had a hepatitis E or some other thing, and that reactivated, and that became negative because of the acute viral hepatitis due to some other virus.
Okay, ma'am.
So you have to expand on that, because without that, you cannot postulate the problem that the patient is having right now.
Okay, ma'am.
And now, what is your take on the history of 12 years back, at the age of 12 years of age?
12 years, he's telling a history of viral hepatitis like symptoms, acute viral hepatitis like symptoms, home management given and subsided within 1 week. Like
but
that.
He's able to recall that history, 12 years.
He was telling at 12 years, this thing he was telling, ma'am. He told both home management and that he remembers.
Or what do you think would have been the viral hepatitis at the age of 12?
Hepatitis B.
What are the possibilities?
Which
Hepatitis
virus?
A and hepatitis A may be the chance, ma'am, because endemic area. So hepatitis A is the first possibility, ma'am.
So A is most likely, no, at the age of
Yes,
12.
ma'am.
And
Yes,
then
ma'am.
it is also possible that he had an acute hepatitis B and it didn't clear and it became chronic. We do not know. We don't have that history between 12 years of age and at this point of time. At this point of time, we don't know whether he was A or B at that stage, no, at the age of 12.
Yes, ma'am. Oh, yes, ma'am.
So there's a question in the chat box: can a reactivation cause eradication of the virus? It is possible, because the reactivation actually destroys, and it is possible that it can become negative. And most of the time, that's what happens. We believe it is acute viral hepatitis. Most of it's reactivation, but we have seen patients getting cleared. Sometimes the patients have even been started on treatment, and then we find that HbA1c's become negative, which is possible. Okay, so any other questions, Viti?
I just want to add that reactivation is the part of body's defense against the virus, because normally in a sort of a carrier state, so when the hepatitis B is inside the liver and the body is not throwing out any reaction at all, there will be the viral load will be in crores, no? And only when the body tries to get rid of the virus, there will be some sort of immune reaction, and then as a collateral phenomenon, you get hepatitis. And a fag end of the natural history, when the immunity builds up, a reactivation can occur, and in fact, the person can become DNA become very low. HbA1c may not disappear immediately. It may take years for HbA1c to disappear. Dr. Sridevi you did not answer that question. What is the rate of clearance of hepatitis B, HbA1c from the blood? What is the natural history?
So 90 to 99% will be in acute viral hepatitis will get negative.
Acute viral hepatitis in adults, agreed, 90%. It may clear up. Suppose it's a chronic sort of chronic hepatitis, chronic infection, or so-called carrier.
Percentage, sir, I'm not sure.
The clearance of HbA1c is considered as 0.5 per year. No, am I right, ma'am?
Yeah.
So it is half percentage per year. So one has to live the entire life to get it cleared. That is why HbA1c practically is always positive, and it is rare to find it negative. Maybe I have seen a couple of patients, maybe less than 10 in my career, HbA1c becoming negative without treatment. With treatment, of course, over a period of time, HbA1c may get cleared. That too very low percentage. That too very low percentage.
But at times, at least when this not reactivation with HEV or new onset HAV, sometimes with the passive hepatic necrosis, sometimes I do find that I usually ask for an HbA1c after the acute episode, just to say in case it has got cleared. But usually the reactivation, as Sir said, it may not be that HbA1c gets totally cleared, but occasionally we can get that presentation. So can you give me differentials for the pain in the right hypochondria?
Ma'am, in this patient is a continuous pain. So
what's your differential? What are the
solid organ pain? First possibility is liver itself, ma'am. Major possibility. And other organs in that place is gallbladder and hepatic flexure of colon. But in that condition, the pain is not like this continuous typical.
Which are the situation where gallbladder can produce continuous pain?
If it is cancer, say a gallbladder.
Yes, it can produce sort of continuous pain, no? So,
yes, sir.
Okay.
The continuous pain. So the continuous pain, and then in that context, who are the patients with a continuous pain and they develop jaundice? So what's happening there? What do you think is happening?
Continuous pain with the jaundice, mainly.
No, pain is there for almost 2 months or so, and then jaundice has come on just for 10 days, if I remember right. Jaundice is more recent. So what is your thought process there?
Some malignancy developing in the liver, which is causing some obstruction in the hilar region or by biliary radicals, ma'am.
Any other possibility? 42-year-old male, any other possibility?
On infiltrative diseases, like tuberculosis is there, tuberculosis and infiltrative diseases like lymphoma.
But most of them will not have the dull continuous. So granulomatous liver disease and all will never have a pain. They're all small lesions.
Pain is not a feature.
Pain is not a feature. They're all expansile masses that will present as pain. No? So you have to consider those possibilities. And it may not What are the other differentials for that so-called mass appearing in the liver presenting with jaundice? What are the possibilities?
Hepatocellular,
Differentials.
hepatocellular carcinoma and cholangiocarcinoma.
But then by now jaundice should have been pleuritic, no? So the patient should have had cholestatic. Although it is 6 days, 10 days, I think, 10 days. No?
Yes, ma'am.
Even they had another clue. This patient had some cholestatic symptoms also after the jaundice developed, no?
Yes, ma'am. Yes, sir.
So first was back pain, then right hypochondrial pain, then jaundice, then cholestasis. So it evolved, no? So that means when the main lesion in the liver occurred, there was no obstruction.
No obstruction.
So what is the situation where the main lesion producing pain sufficiently big to produce pain and infiltrating the nerves, etc., but not causing jaundice, but over a period of time it is producing obstructive jaundice. So what is the scenario there?
Large hepatocellular carcinoma with the nodes causing biliary obstruction in the later.
That is possible, yes.
Yes.
Just add, because you said about granuloma and tuberculosis, etc. See, diffuse enlargement of the liver produces pain only when it is acute. For example, acute hepatitis, or very rarely acute congestion of the liver due to suprahepatic reason like congestive heart failure. Such person, of course, tender liver you can find on palpation of the liver. Okay, but acute distension of the liver capsule, mostly acute hepatitis, or distension of the liver capsule due to venous congestion or outflow obstruction. These are the situations you get pain. But chronic enlargement of the liver seldom produces clinically significant pain. You may elicit some tenderness, but not the patient won't complain with or come to you with the pain as a major complaint. Okay.
Exactly. Yeah. So I agree to that. So I think now you can summarize it. Yeah, I think that's fine. Okay. You can give a good summary.
42-year-old male, known case of type 2 diabetes mellitus, presented with complaints of backache for 4 months with history of alternative medication intake, later developed right upper quadrant pain, dull aching, continuous pain for 1 month, followed by jaundice associated with the pruritus and clay-colored stools, and along with the anorexia and significant weight loss in the absence of prodromal symptoms.
Yes, anorexia and weight loss is for how long?
3 months. 3 months.
I think that should be the first history, no? So if already that is the most important history.
Yeah, that is an important symptom.
That is the most important history. So if you start with anorexia and weight loss, and then the patient has back pain, then if you are almost hitting on the same, whether the patient has got more of a pathology related to anorexia and weight loss as a metastatic bone disease right at the beginning.
Yes, ma'am.
Here also you have added CAM intake. Unless the CAM intake is relevant in the diagnosis, like for example, you consider CAM-induced delay or etc. Please don't bring in that CAM there.
Okay, sir.
Because it becomes totally irrelevant in understand. Because in this patient there is pain, right hypochondrium. We are thinking some sort of neoplasm producing obstruction. So CAM and CAM-induced delay doesn't come into the picture unless you think of a delay due to CAM, which is very unlikely in this case. So don't try to get into trouble by adding unnecessary things.
I'm going to ask you one simple temporal relationship. So do you think that anorexia and weight loss would have preceded the bone pain? Or do you think that the bone pain came along with anorexia and weight loss? This is most important and crucial in this patient. It is not possible that the pain in the back came along with anorexia and weight loss. This is just not possible. And mind you, an orthopedic surgeon or whoever the person is, if the person has lost so much of weight and the person has got anorexia with the back pain, he cannot just take a simple plain X-ray of the lumbar spine and say that nothing's wrong with you when he's losing weight and anorexia. That is the most important history of this patient. And then once you suppose, like today we had a patient who came with severe anorexia and weight loss for 8 days. So what is your take? If a person comes with long-standing history of anorexia and weight loss, it's some chronic disease. It's more of a chronic disease. I think of tuberculosis, I think of lymphoma, I think of benign diseases, I think of other conditions where the person may be having early satiety, nausea. So I'll get into that mode. So anorexia and weight loss cannot come along with the abdominal, with the back pain in this patient. So if I have a patient with anorexia and weight loss, what are your differentials for a patient coming with anorexia and weight loss to the clinic, to the outpatient clinic? That is your differential for this particular case. In that background, the patient has developed back pain, and then he develops a pain in the front, which becomes quite easy to understand what is happening to the patient.
Yes, ma'am.
You understand? So it
Yes,
maybe there's a pathology in the lung, and that's got metastasized to the bone. So maybe there is he's got tuberculosis, and therefore that's a pathology in the bone. So what are your differentials for a patient with anorexia and weight loss? And that is the most crucial history that you should take. If I were there, I would bring anorexia and weight loss into head, and then say within a few months he noticed this. It would have definitely preceded. 100% it would have preceded the backache. So that we don't have to beat around the bush, as to what are the possibilities. Then the differentials become shortlisted. They become really shortlisted if you have an anorexia and weight loss. You agree to that, Dr. Viti?
Yeah. I think, Srividya, you are not convinced. See, for metastasis to occur in the lumbar spine or anywhere in the body, the primary has to be there for some time.
Yes, sir.
The primary and the metastasis doesn't occur on the same day. So it evolves, no? Metastasis is the advanced stage of a disease, cancerous disease. So at some point of time, the primary has to there. It has to attain sufficient size, then it produces systemic symptoms. Okay, along plus or minus metastatic symptom. So unless you think that the primary is so small and metastasis are throughout the body, and then only it started creating problem. Then of course, then you won't be able to explain the pain in the right hypochondrium and jaundice within 1.5 months, no? So what ma'am told is absolutely right, because if the patient had a CA to begin with, anorexia, weight loss can be explained. Then over a period of time, back pain, then gradually right hypochondrial pain, then jaundice. So and the story becomes very simple. But you have to answer that question which ma'am asked you. What are the causes of anorexia and weight loss?
Yeah. What are the causes of anorexia, weight loss, number one? And what are the metastatic lesions in the bone that can present in a patient with anorexia and weight loss? Sorts of sites, common sites, primary site that can present with metastasis, and what percentage where you will not know the primary at all. It's very important, no? Patient coming with anorexia and weight loss with a backache, 99% that has preceded. So now it is easy to understand what's happening to the patient. So the lesion is actually in the liver first, and then it is gone to the bone, rather than the other way that you described. You have to build up the history in such a way that you take the examiner towards your diagnosis. Okay, now, since we do not have that history, can you tell what are the common primary sites that can have a metastasis to the bone? Give us some differentials.
So, ma'am, the thyroid, primary sites which causing bone metastasis, thyroid, lungs, non-small cell carcinoma lung, then liver hepatocellular carcinoma, then Wilms tumor.
Hepatocellular carcinoma of the liver, I have not heard of. I mean, I've never seen a liver cancer presenting. We've seen so many liver cancers. No, I've hardly ever seen a Mets to the. What are the other common GI malignancies that they keep saying? No, look for bone tenderness, examine the pelvic, do a compression test for Mets. Which are the common sites? Stomach, pancreas. These are the ones that can cause metastasis to the bone. Prostate.
Pancreas, prostate, and Wilms tumor, kidney.
Yeah.
Renal cell carcinoma.
So these are the ones that are more important, where they present as a primary, and then they present with this. This is one. Number two is the other question was can it be some granulomatous disorders like histoplasmosis? The histoplasmosis.
Histoplasmosis can cause.
Exactly. Yeah. Then multiple myeloma.
Histoplasmosis.
Look at the differentials now. You have a wide differential. It can be histoplasmosis. It can be one of the granulomatous disorders, xanthomatous disorders. Can be multiple myeloma.
Histiocytosis.
At any extent, I will allow you to have any level of imagination. Can multiple myeloma present like this? Is it simply possible?
Yes, sir. Multiple myeloma.
Multiple myeloma, bone pain. Start with the bone pain.
The right hypochondrial pain may be due to rib fracture, and the liver involvement may be totally different. Okay. They can have various, of course, amyloidosis is one of the presentation, but don't present with jaundice. Amyloid.
I'm not moving to the liver. What I'm trying to say is, if the anorexia and weight loss had come and the patient who came with you back pain,
Bone pain.
then your differentials will be some of these.
Okay, anorexia, weight loss.
In that context, now the patient has a pain in the anterior abdomen, in the front of the abdomen. You understood? So
Yes,
I would really thrash out the history there and then come to a conclusion why with this patient. And I would have built up the history in a different way. I would have said that actually the patient actually had a pain in the right upper quadrant, blah, 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 and then also had back pain, and be 100% sure that you're not dealing with the primary in the stomach or the colon or the pancreas. Can it be a pancreatic pain?
Ma'am, it is continuous pain, right upper quadrant. So
No. Back pain.
Back pain. Back pain is a boring type usually, ma'am. It's a spreading pain actually. It's a large area involvement is there.
Sometimes it may just present with back pain and may not have any pain or boring pain. Boring pain is all acute or chronic pancreatitis, no? But it was just a tumor. Can it be a retroperitoneal tumor? We're just taking for discussion. Can it be a retroperitoneal tumor?
Yes, ma'am. Yes, ma'am.
That's also a possibility. Because retroperitoneal tumor has to come as a differential. And in that context, you can get mets in the liver, you can get mets in the bone. No?
Yes, ma'am. Yes, ma'am.
So you have to read about those retroperitoneal tumors which can present in this manner. That is pain at the back, causing radicular pain, radiating to the lower limb. And this is on the background of anorexia and weight loss. And the history is short, it's February to May, just 3 months history. And it's rapidly progressing.
Yes, ma'am.
So all your lymphosarcomas, all the retroperitoneal tumors. I've not seen the PowerPoint earlier, so I'm just having a wide discussion that these would be your differentials. Okay?
Okay.
So you have to read about retroperitoneal tumors, will be a discussion. And in all the patients, Dr. Vinay Kumar's point I always like, smaller the lumen, symptoms will manifest first. Anorexia, weight loss will come later. Wider the lumen, say stomach. The stomach patients will have anorexia and weight loss and then present with obstruction. It's a very nice logical way of understanding. So the two will never come together. If you have a patient with dysphagia, anorexia and weight loss cannot come with dysphagia. The patient will first present with dysphagia, and over a period of time, they start losing weight. Anorexia will be the last symptom. Likewise, if you have a pathology in the left colon, you will first have bleeding for rectum, anorexia, weight loss will come much later. So you cannot put the two together. You cannot put the two together. I hope you have understood what I'm trying to say. Smaller the lumen, symptoms will manifest first if it's a tumor, and the anorexia and weight loss will come on much later. The manifestation. So they're all the patients where you pick up the lesions early.
Okay, ma'am.
You understand?
Yes, ma'am.
So keep this in mind. Keep that in mind, and in that context, this is what you have to understand, that this is something that is, if I were there, probably I would bring in the pain, the right hypochondrium first, and then bring in the back pain. I will start with anorexia and weight loss, bring in the pain, and then bring in the backache.
Okay, ma'am.
I'll be comfortable with my discussion because already have a clue that some doctor has said there's a mets in the liver and there's some problem in the liver, there's some problem in the bone.
Okay, ma'am.
Okay. We always say, build up a story so that you don't divert the examiners to some direction. Bring them together so that you're coming towards a particular diagnosis.
Yes, ma'am. Yes, ma'am.
Okay. So I think your summary is 42-year-old male, diabetic.
Present corrected summary.
No, that's okay. With the pain and some backache and this. But where's your anorexia and weight loss? Look at that.
I put in the last, actually, associated with anorexia and significant weight loss.
Yeah, so have you understood?
Yes, ma'am. Yes, ma'am.
I would always consider this possibility. I would always bring in what is first. I know it is malignancy. Hopefully, it may be into the closest. We do not know what it is. But I would consider that symptom and then bring in this point. Okay?
Yes. Okay, ma'am. Okay.
What are the other causes? I'm just thinking aloud. Can it be some HIV, high-risk behavior which we have not got the history, and the patient's got anorexia and weight loss, and in that context, he's developed a tumor? Any other things that you would consider? I'm just thinking aloud. Anorexia, weight loss. I would think of a high-risk behavior, tuberculosis, Kaposi sarcoma. Yeah. So, but they all have other symptoms. So that's unlikely. Okay.
Extensive tuberculosis is one.
Disseminated
tuberculosis is a
tuberculosis.
Yeah.
Yes.
All these long-standing, when they have anorexia and weight loss long-standing, I think we should consider all these chronic diseases as a differential. Okay. Okay. We have who's Harish is the other person. No? Anyone else would like to
Ramya and Harish.
Ramya and Harish, at this stage, you can pitch in and ask any questions or you have any doubts about the presentation. Yeah, Harish.
Ma'am, like in this case, can we consider hilar lymphadenopathy, ma'am? Like
for the jaundice, sir? Yeah, jaundice it is infiltrative. It's gone beyond, no? So it is either interporta or it is extending into the biliary system. That is for the discussion. That's okay, no problem.
Okay.
But I think the other thing is the past history of acute viral hepatitis B is also a major comment that you made. And this was not expanded at all in your history.
Yes, ma'am.
Yeah, so how do you say that it was acute viral hepatitis? There'll be a lot of discussion on this, whether it is reactivation, is it naive, acute? How did he get the hepatitis B? Were there any family members? Is he case with tattooing? He's got high-risk behavior, he's got drug engagement. All those things will come up.
Okay.
Okay, so I think be careful with that history, past history of acute viral hepatitis B.
Okay, ma'am.
Okay, okay,
Okay.
move on. Let's move on.
Did you say differential hypothesis, ma'am?
No, what's your syndromic diagnosis?
Syndromic diagnosis.
What's your syndromic diagnosis? What are the 5 components of syndromic diagnosis? What is your broad syndromic diagnosis?
This patient, ma'am, cholestatic jaundice. Probably, actually, in this after history, I can't differentiate between intrahepatic or extrahepatic.
What is your syndromic diagnosis? Syndromic.
Vidya, you just told one thing. I cannot say whether it's intra or extrahepatic. In presence of pain, if there are cholestatic symptoms and if the pain is somewhere in the biliary or hepatic region, you have to always consider extrahepatic. Pain with cholestatic symptom.
Mass is not actually history of mass.
No, there is no need. Now we'll ask the question. What are the bedside clues to the intrahepatic and extrahepatic cholestasis? At bedside, when you take history and when you examine, what are the clues by which you say it is intrahepatic or extrahepatic?
Extrahepatic pain.
Srividya, never ever say I cannot differentiate. You have to say, I mean, first, before that question, just give you syndromic. Tell your syndromic guide. What is your syndrome in this patient?
Cholestatic jaundice, probably extrahepatic cholestasis.
What else? You had the back pain. You had so many other problems in this patient, no?
With bone metastasis, probably bone metastasis.
He has,
and with the hepatitis,
your broad syndromic diagnosis will be a lumbosacral strain or pain with radicular presentation. That's your broad. That is definitely there. With jaundice, most likely cholestatic type, probably extrahepatic biliary obstruction, complicated by anorexia and weight loss, with a comorbidity of diabetes mellitus and a possibility of a hepatitis B viral infection, whether it is chronic, E antigen positive or negative, we do not know. It is reactivation, and maybe they did a card test. They were just done a card test and they said HbA1c positive. Next time they do ELISA and it is negative. So that's also possible. They really have, but there is some clue, so that will come as a query. This is your broad syndromic. This is how you describe. Syndromic is syndrome, and then you have possibility of extrahepatic, and then they will discuss is it this thing, and then say my differentials for the cholestatic jaundice in this particular patient are, then you give your differentials at this stage.
Yes, ma'am. Okay, ma'am.
What are your differentials?
Differentials will be
what will be your first differential in this patient?
hepatocellular carcinoma with bone involvement.
So, but you said intrahepatic, you said extrahepatic biliary obstruction.
With the nodal in.
I would say with a probable mass lesion in the liver. See, I would say this. My differential will be like this: lumbosacral strain due to this, whatever it is, with a mass lesion in the liver, presenting as cholestatic jaundice. Now it works out well with anorexia, weight loss, complicated anorexia, weight loss, and possible bone metastasis. That's another complication. and with the comorbidity of diabetes and a possibility of a hepatitis B, lurking hepatitis B virus infection. Now it's easy to describe. And now we'll give you a differential. Mass lesion may not always be palpable, no? Now we'll ask you what are the types of, okay, now we'll give what are the mass lesions in the liver that can present as cholestatic jaundice is your differential.
Hilar cholangiocarcinoma, hepatocellular carcinoma with nodes.
Between the two, which one would you choose? In a patient who's got HbA1c history and he's got
Hepatocellular carcinoma.
Exactly, I would consider hepatocellular
carcinoma
ahead. That will be my first differential. And when can this present as cholestatic jaundice?
When nodes, if large hepatocellular carcinoma, or when the nodes in the porta.
So one is it's a mass lesion, large mass lesion, and he's got a pain that is there. So you have a diffuse type of HCC, multicentric HCCs, they call it, can present as just a pain. And if there are nodes at the porta, you can get obstructive jaundice. If there's infiltration into the biliary system, again, you can get obstructive jaundice. So these are the possibilities. Okay, so that is
among these two, the bone metastasis seems to be less for hepatocellular carcinoma. So even though we consider it on the basis of hepatitis B positive history, if we think that the lumbosacral pain is due to bone metastasis, then technically it becomes unlikely, less likely. I won't say unlikely, less likely. We may have to keep our options open.
So just look up, even I would not be able to tell, just look up the mets to the bone from the various portions of the GI tract, liver, gallbladder, as well as the entire body, you know, like from the thyroid, lungs. What will be the percentage of mets? Just have a look at that, because we talk a lot of mets from the GI tract, but actually it's less than 5%. If you get into the review of literature, you'll find that it's less than 5% that actually goes as metastasis to the bone.
Yes, ma'am. 3% HCC.
That's what I'm saying. So it's very low, so less than 5%. So therefore, once you have the figures, based on that, then you can put your bet on what is the likelihood. So one is hepatocellular carcinoma, large HCC. That can explain everything. Anorexia, weight loss, pain is there, mets, or it's mets, or it's unrelated to mets also, we do not know. So that tells you that. Okay, now number two, next one would be intrahepatic cholangiocarcinoma. That also presents as large mass lesions, no?
Yes, ma'am.
Intrahepatic cholangiocarcinoma will come as, and they present as pain. They present as pain and jaundice comes on much later. So that's the other possibility. So these actually would be, can it be a mets to the liver?
Yes, ma'am.
Because I had one DD that back pain, could it just be a chronic pancreatitis, a pain that was there, and it is actually a retroperitoneal tumor, and that has got metastasis to the liver? That's the third possibility. If you have brought in the back pain and then the pain in the front, then retroperitoneal tumor with extension causing a pain in the right hypochondrium, presenting as a tumor, presenting as obstructive jaundice is the other possibility. Large tumors. Okay, for me, these three would be the differentials. Dr. Niti,
I think if the patient is in North India and if the patient is female, we'll have to entertain the possibility of GB carcinoma also.
Yeah.
Especially slightly older person, because in earlier, you will be given in some other centers, you will be out of Kerala or Tamil Nadu. The current style, you are having examination in your own center. But when you go to different places, you should also know the prevalence of such diseases there. So if you have a North Indian patient, you have to think of, especially female, GB carcinoma, because everything will fit in, no? Pain, subsequent jaundice, obstruction, everything will fit in. Okay.
For discussion, can it be a hypernephroma? You have that syndrome, no? What is it called? What's that?
Which one?
That hypernephroma, no? A tumor, and we get a tumor in the liver.
That's the one producing renal vein thrombosis, IVC thrombosis, etc., etc.
No, not that. It goes, what is it? What's it? Foster syndrome. I forget the name. Where you have Stauffer syndrome. Can it be
Stauffer's renal cell carcinoma?
Can it be that?
Cholestasis.
Can it be? See, look at the differentials now. He's got a pain at the back, and the whole back pain maybe just be a hypernephroma, and he's got mets in the liver, secondary, so it's a Stauffer syndrome, and that will be this is STAU, Stauffer syndrome, and that is still a possibility.
There is a possibility. That's cholestatic jaundice.
Exactly. Look at the huge differentials now you have. Retroperitoneal tumor, then you have because the pain is at the back in the beginning. But you think hypernephroma by now should have been 3 months is okay. It is a time. It's just that 3 months. It is progressive. It can metastasize to the bone. It can metastasize to the liver. So I would even put my bet that are we dealing with a hypernephroma presenting as Stauffer syndrome? Have you followed? Now,
Yes, ma'am.
disseminated tuberculosis, I will not consider this patient. Maybe lymphoma with mets in the bone and all, to me, I have not really looked into that. But disseminated tuberculosis, definitely not.
Even
And
pain is difficult to explain, no? For
you cannot.
right hypochondrial pain is unusual for lymphoma.
And with no systemic symptoms.
Tuberculosis also. Back pain may be explained because if
Yeah.
there is sports pain, but
What's fine?
right hypochondrial pain will be difficult to explain.
Explain in tuberculosis. Okay.
Okay.
I think shall we invite the
Move
others?
on. Yeah, now
Whether
move
they
in.
have the differential
Harish,
diagnosis. Ramya and Harish.
any other
Do they have a
differentials?
differential
Harish and
diagnosis?
Ramya.
Ramya, are you there?
Yes, sir.
Yeah,
Do you
tell
have
me
any other
differentials.
differentials?
We thrashed out the whole thing. I think we cannot have beyond this something coming out of it.
Okay,
So,
for completion's sake, you did not answer my earlier question. How will you differentiate extrahepatic from
noted. Yeah,
intrahepatic
that's important.
at bedside? At bedside.
Bedside.
So presence of abdominal pain and
Okay, pain.
pain.
Okay, pain.
Then history of like abdominal visible lump.
No, history. First, history. Finish history.
History, yeah. History of any abdominal lump.
Abdominal pain, agreed. Then feature. I will.
Then features of
cholecystitis.
Pain
Already
with
cholecystitis
fever.
is there, no?
Fever.
That's
Fever.
why we are trying to differentiate whether it's intra or extrahepatic. So pain,
Yes,
features of cholangitis, like chills,
Yes.
rigor, and that means Charcot triad, no? Okay,
Yes,
so
Pain with
cholangitis,
fever.
pain
With fever.
yeah, pain with fever, or even pain otherwise. Okay, then history of surgery in the upper abdomen, hepatobiliary surgery in the past, or history of endoscopy intervention of the biliary tree. Okay, such things will give. On physical examination, significant hepatomegaly, and a palpable gallbladder or a mass in that region. Okay, so these are the clues, bedside clues.
Yes, sir.
So if pain and cholecystitis is there, I think you have to, even in the absence of other things from the history, you will have to vote for extrahepatic because you are likely to be more correct when you vote for extrahepatic in such situations. Okay. Okay, ma'am.
This is Dr. A.S. Puri's favorite. If pain and fever is present, it's likely to be extrahepatic, but its absence does not negate the absence of an extrahepatic biliary obstruction. But if you have pain and features of cholangitis, you can almost vouch that you're dealing with extrahepatic biliary obstruction. Okay, and if the patient has the other form, the pain with cholestasis, again would favor more of extrahepatic biliary obstruction rather than intrahepatic. That's the way Dr. V.T. summarized it nicely. So that's what you should consider. Okay. Okay. On examination, quickly, you can just go through.
Patient is conscious
Just the salient findings.
In that, patient is having icterus, lymphadenopathy present, generalized lymphadenopathy present. Occipital lymph node was palpable, and right and left axillary lymph node. In that, left axillary node was approximately 3 centimeter, and multiple cervical nodes was palpable, but it's small, less than 1 centimeter. And inguinal nodes was on the right side was also palpable. All are firm, mobile, smooth surface, discrete, non-tender, and no redness over the overlying skin. And BMI was 90.
What's your comment on the lymph nodes?
It is not an inflammatory node, ma'am. There's no non-inflammatory nodes. And
what's your comment? So generalized lymphadenopathy. Generalized. What are your differentials now?
Lymphoma will come to the first possibility, ma'am.
Lymphoma is one, but just keep the metastasis and this thing. Metastatic as well as the liver
cholangiocarcinoma can.
No, not generalized lymphadenopathy. Tuberculosis now.
Tuberculosis.
Although you've not picked up the matted lymph nodes.
But matted lymph nodes is not there.
Can it be sarcoidosis, tuberculosis, lymphoma,
then
granulomatous, other granulomatous disorders like
histoplasmosis, toxoplasmosis.
All those will come as a DD, no?
Yes,
but in that context, just keep this patient in mind who's got some bone pain and he's got some pain in the right hypochondrium presenting with jaundice. That jaundice now may still be some other nodes at the pota, no?
Yes,
it's got
yes,
ma'am.
Yes, ma'am.
Okay, then.
Okay, BMI was 19.6, mid-arm circumference, right side
Okay,
20
that's okay.
and
Just move
left
on.
10.
Yeah.
Triforce. Temporal fossa hollowing was there, scratch marks present, and no evidence of cutaneous malignancy markers or no any stigmata of chronic liver disease.
So just
No
hold
weight
on.
loss.
So now you understand that anorexia and weight loss importance.
Yes, ma'am.
So you see now, so to me, when I saw anorexia and weight loss, I would first look for lymph nodes of this patient. No.
Yes, ma'am.
So that's the way you move forward. In that background, then you have some other pain and some other pain. But for this particular patient, there's nothing much more to be done except just take a tissue biopsy of the lymph node and finish off with the diagnosis. No.
Yes.
Did the patient notice the nodes?
No, ma'am. That is the thing. Actually, I asked him again here. Didn't notice this note.
Okay,
He's
fine.
not
That's
giving
okay.
a history.
That's okay. Even physicians miss, so it's okay for the patient. Okay.
So,
Okay, then.
Then coming to systemic examination, oral
Anything
cavity,
positive?
positive liver was liver
Palpation.
palpable 2 centimeter below the right costal margin. Firm. On examination, it was non-tender, smooth surface, rounded margin. Left lobe was also palpable 1 centimeter below the sternum.
Now 1 minute. Never comment on the lobes when you're palpating.
Okay, ma'am.
You can
Okay,
always have an atrophy hypertrophy complex. Be very
Okay.
simple and plain. Just say liver is palpable in the mid-clavicular line and liver is palpable in the mid-sternal line. Finish.
Oh, okay,
Do
ma'am.
not comment on the left lobe and right lobe. For all you know, there may be an agenesis of the left lobe and it's the right lobe that you're palpating. Be very simple and plain. Yes, liver is palpable, so many centimeters below costal margin here and so many centimeters in the mid-sternal line. And then describe the rest of it. So
Okay.
it is firm, 2 centimeters.
Firm, smooth surface and rounded margin.
Okay.
Rounded margin.
And spleen is also
Spleen
palpable.
is also palpable 6 centimeter below the left costal margin, firm in consistency, sharp border, and non-tender, and moves with respiration. Splenic notch was also palpable. Gallbladder not palpable.
Any other mass that you look for? You would especially look for some masses, no?
Nodes, retroperitoneal nodes can be palpable.
Retroperitoneal nodes will not be palpable.
No,
except in testicular tumors, we find that the nodes are large, or in patients with HIV. Otherwise, retroperitoneal nodes are generally not palpable.
Okay.
So, because they're all deep-seated, they're all posterior, no? So you may not feel. But what you can feel is some other retroperitoneal masses. That is what is important, like lymphosarcoma or large tumors from the retroperitoneal region. In DNP exam, I remember in Delhi, we had huge masses which were non-anatomical but presenting anteriorly, and they all turned out to be retroperitoneal masses.
Okay.
But those masses may not have a generalized lymphadenopathy. So just keep that in mind, okay?
Okay.
Nothing else was positive. Okay, what else did you look for in this patient? What else did you examine? Most important. Spine, where's your spine examination?
No body deformity, local tenderness present in the lumbar, sacral, and iliac bone region. SLR was negative. No joint movement. Joint movements. All joint movements were normal.
So how do you look for bone metastasis? What's a clinical examination? So
local tenderness.
One is to compress the pelvic bone compression side to side. And if the patient has pain, that's one of the signs that they say that you can't get bone widths. Okay. Okay. And then local tenderness. And then what about the radicular pain that the patient had?
SLR was negative when examined.
SLR was negative. Okay.
Other systems, the nervous system was normal. So all reflexes and sensory motor system was normal.
So now what's your diagnosis?
Now it is first diagnosis will be lymphoma, ma'am.
Now just look at that.
Jaundice with hepatosplenomegaly and generalized lymphadenopathy.
That's how it works out, no? So that's what I said. So if you had that anorexia and weight loss coming down from there, and then gone into this, it would have been easier. And you have to play after examination. You have to play low on the pain in the right hypochondria. You're not bringing discomfort or anything, because this particular patient with 2 centimeters cannot have a pain in the right hypochondria. You agree to that?
Yes, ma'am.
So you are the person who's examined the case. I do not know what the case is. Yes, but if I were in your place, I will go, I'll bring down on the history on the pain in the right hypochondria, will not attach much importance, but just give history of that jaundice coming on recently. Then if I have an anorexia, weight loss, and then the patient has got jaundice more recently with a back pain, then my differentials will be tuberculosis, lymphoma, sarcoidosis, all this will come as a D.
Okay.
Xanthomatosis, granulomatous, all these chronic disorders presenting as anorexia, weight loss, and then a lymphadenopathy, then I would have almost hit at a diagnosis. You understood?
Yes, ma'am.
You people are at an advantage that you've examined the case as a whole. Once you examine the case as a whole, this is the one thing that I was always taught in CNC. Always one thing that Professor Martin always said: just build it like a story. so that the examiners get directed towards you.
Okay, ma'am.
Okay.
Okay.
Okay. Now, what's your differential?
Cholestatic jaundice, infiltrative liver disease.
Now, infiltrative lymphoma will come high on. Is Hodgkin's, non-Hodgkin's? What is it?
Non-Hodgkin's lymphoma.
So one is, it could be NHL. Okay. Then the other one
Disseminated
is other causes. No, it's not matrix.
sarcoidosis,
Sarcoidosis,
and lymphogranuloma.
and other
toxo-
granulomatous. Other granulomatous, the destructive
histoplasmosis,
ones. What is that capsulator? What is that?
Plasma capsule.
histoplasmosis.
Yeah. That's something.
Toxoplasma, I think it's not
Oh.
that. And another thing,
Toxoplasma.
you said
Histoplasma
about some-
granulomatous.
Yeah.
Okay, histoplasma agrees, but not toxoplasma. And
Not
you are
toxoplasma.
telling about lymphogranuloma.
Brucellosis. Brucellosis.
So infections, chronic bacterial infections, neoplasm, fungal infections, all those
Leukemia.
parasitic disease, all those things can be.
Leukemia will not come as a DD here.
Uh,
Which leukemia are you talking about? In this patient is so much of
It is-
lymph nodes and hepatosplenomegaly. Leukemia, doctor, then they'll ask all about leukemia. This is a presentation of a CML or acute
No, ma'am,
lymphocytic. This is not the
no,
presentation.
no.
Don't, you have, it's basically a bone lesion with nodes. That's your differential now.
Yes, ma'am. Bone
Yeah,
lesion.
yeah. And in that, there's one small component of jaundice. No, this component of jaundice is very small, the 10 days. And the pain, I would really not consider the pain of, it may be a rib metastasis. He may be having rets in the ribs. That is one possibility.
Yes, ma'am. That's a possibility. Yes, ma'am.
Meeting, we can move on.
Yeah, we can.
So now, actually, the case is short. So
Ramya,
how will
we'll ask the next person how to investigate.
How will you investigate?
Dr. Ramya, please.
So initially blood investigations.
No, what is your aim of investigation? This patient. This patient comes to you to the OP, and you have these huge nodes, and you have just let us speak like a specialist. What would you do in this patient right in the beginning? One will you ask for a CBC you wanted. Okay, then.
And then LFT to look for the cholestatic picture. And
if you want to cut short on the expenditure and other things, CBC, yes, you need one. Then what are the things that you'd ask for? What is the first thing that you'd ask for? I would ask an ultrasound scan of the abdomen, get a chest X-ray done, and go straight to a lymph node biopsy. No?
yes, ma'am.
That's it. That's all that I need with this patient. I will not even ask for an MRI spine. I'll ask for this, and based on this, then I'll proceed if it's going to change my line of management. Supposing this patient came to you in the OP, that's what we're asking as a consultant. Tomorrow you say you're a consultant. What would you do? This patient comes to you in the OP. You ask for a basic CBC, you ask for an LFT, and then you proceed for a
Lymph node biopsy following a chest
ultrasound. No, I'll ask for an ultrasound scan. No, supposing I pick up more nodes, and I'm able to pick up retroperitoneal nodes, and I pick up a liver, and I get these SOLs in this. We had one patient where we picked up SOLs in the spleen. And then I said, oh, it's not my problem. It's hematologist domain, and I'm coming out of it. And it turned out to be right that the patient lymph node biopsy came as non-Hodgkin's lymphoma. So you need an ultrasound because we also suspected cholestatic jaundice. Maybe as gastroenterologists, we may have to intervene in such patients. I'm just asking you, how would you proceed as a, here I will not ask for blood sugar and all that. No, we want a quick diagnosis so that we can manage the patient. And blood sugar and all will be part of the management, subsequent management after making a diagnosis. Do you agree to that?
Yes, ma'am.
Yeah, and we need a basic creatinine in case you want to stage the disease, but I think it's more advanced. So can we have that information on CBC?
X-ray.
Yeah. So now comment on this.
There is anemia with a HB of 10.7 and total count is only mildly elevated, 10,700 with the platelet borderline 1.54 lakhs.
Comment on the LFT.
LFT is showing a predominantly direct hyperbilirubemia with elevation in alphos and GGT, predominantly suggestive of a cholestatic pattern.
What extrahepatic, intrahepatic? 724 and gamma GT of 330.
More likely extrahepatic.
Extrahepatic. And the possible cause could be now again nodal. It can be nodal.
Nodes at the porta hepatis.
One causing compression, or it could be that it is at the periamplar region of gastroduodenal nodes causing extrinsic compression. So that is also a possibility. And what's your comment on AST-LT? AST-LT. What is your comment on AST-LT? It is not very high, no? Do you
Yes,
think the
they're like
patient?
less than 5 times the upper limit of normal.
Yeah. Okay, then. So what's your comment? This doesn't look like intrahepatic, no? Intrahepatic will
Yes,
have a
more-
much, yeah, it is more of extrahepatic.
Extrahepatic.
Okay, then RFT is normal.
Normal.
LDH, comment on
LDH
LDH.
LDH is elevated.
Hmm.
As we see in some non-Hodgkin's lymphoma, it has a prognostic value.
That's okay. We do not know what it is. Would you ask for CA99 in this patient? I would not waste money on that. Would you ask for a CA99 in this patient? Practically, I'm asking. See, this is a practical issue. In this particular patient, who's come with generalized lymphadenopathy, with hepatosplenomegaly, with some pathology in the bone. What will be your take? So CA90 will not come in. Would you ask for serum uric acid? Would you ask for any other investigations? What else would you want to know now? Let's move on.
Next slide.
Probably calcium levels, because we were thinking of sarcoidosis also as a possibility.
Oh, yeah. Okay, go on to the next slide. Next slide. So anti-HBC core is positive. What about anti-HBS? What is anti-HBS? That's more important, no?
Anti-HBS actually not done, ma'am.
Is it important or not important?
Yes, ma'am, important.
No, that's the only one that will tell you it's a past infection, no?
Yes, ma'am.
In this particular patient with anti-HBC total, will you just ask for HBV DNA load? Answer this, Dr.
Yes.
Srividya.
Ma'am, yes, ma'am. I can't get, ma'am.
The patient is HBsAg negative, anti-HBC total positive. What will be your next investigation of choice?
Anti-HBS, ma'am.
Anti-HBS. You would not. I will not ask for HBV DNA.
Okay,
If
ma'am.
anti-HBS is positive, then he is likely to have a low HBV DNA or not detectable. No, it's a past infection.
Yes, ma'am.
So we don't have that information. It's not
Yes, no, ma'am, no, ma'am.
You cannot make a comment that the patient's got an occult HBV infection. Agree, Dr. Viti?
Yeah.
Okay.
Because HBsAg is negative. So
Yeah,
in ordinary situation, we don't expect HPV DNA to be positive. It's not treated.
So Ramya, what's
So-
the next investigation of choice? What will be the next one investigation of choice, this patient? We'll give you the ultrasound, but what will be the next investigation of choice? You'll ask for a lymph node complete excision biopsy. No? We'll do an excision biopsy with immunohistochemistry based on whatever is the finding. Can we have the next slide?
It's an ultrasound abdomen done outside.
Okay. Shows multiple hypoechoic areas, mildly dilated IHBR, edematous gallbladder, moderate splenomegaly. Just see this. I have not seen your slide. Look at this, because we had an identical case, multiple hypoechoic lesions in the spleen, suggestive of a lymphoma. We thought it was gamma ganglion bodies, but actually, when the node came as positive retrospectively, then we realized all SOLs in the spleen in a patient like this, you should consider the possibility of a lymphoma. Okay, and just see that enlarged paraaortic and peripan. So ultrasound is informative and
Yes,
gives
ma'am.
you a clue. But final diagnosis will be based only on
lymph node biopsy.
lymph node biopsy. And always when you what are the things that you will tell the pathologist when you're doing a lymph node biopsy when you send the specimen? You'll be taking off, so you have to do a cross. You have to take a section and see whether there's caseation. If it is firm and hard and non-caseating, you have to tell them to look for a immunohistochemistry staining and classify or stratify the lymphoma. Okay, next slide. Go on.
It's the outside CT, plain CT, showing hyperdensity in the areas with mild biliary radical dilatation only. Actually, it's plain CT done outside now.
Okay.
And it's showing splenomegaly and bone lesions.
That's a good slide. Yeah, bone metastatic lesions. Sure.
And actually, patient presented with this symptomatic cholestasis symptoms pruritus was so severe. So
no, first let us know what was the lymph node biopsy before we go to the
yes,
RCT.
then
because I don't know what we are getting into. No? What was excision biopsy?
Yes, ma'am. This is the axillary lymph node excision biopsy specimen showing infiltrate of uniform size cells and including the large and small cells, and total destruction of the architecture, and the sinusoids are also disrupted, and they recommended it as discrete small, predominantly admixed with the large cells, sinus not preserved. And in lymph node, they told it is a low-grade lymphoproliferative disorder, mixed, diffuse, and follicular grade 1.
Fine. So there's a type of lymphoma. I would not know much about this. What was
This,
their findings?
here, bone marrow biopsy was, iliac bone biopsy was also done, and this bone biopsy showing large cells, mainly large cells, and with the marrow is fully infiltrated and by the fibrous stroma, and they commented marked desmoplastic stromal reaction with diffuse infiltrate and in suggestive of large cell lymphoma. So both pattern was also there. Follicular lymphoma and large cell lymphoma pattern was there, and IHC done showing BCL2, BCL6, CD20, CD10, and so suggestive of diffuse large B cell lymphoma.
You can just tell us something about this, no? Just that immunohistochemistry staining. Because from now on, management is only, I would pass it on to the hematologist. Okay, just tell, can you just tell us?
BCL2, BCL6, CD20, CD10 is more suggestive B cell lymphoma markers, ma'am.
Okay, so that's what, okay. And what about the Ki67 and
activity index, ma'am, proliferation index.
So I think please read about this immunohistochemistry. No? They may ask a little bit more on this particular aspect. Okay. So now we have this. Now what should you, now the patient has got other problem. Would you ask for a PET CT and all in this patient? Just think practically, Practically, what would you do? Now our issue is, now we've established that the patient has got a diagnosis of a lymphoma, okay, with a METS, and there are metastatic lesions. Okay, now his problem is pruritus. How intense is the pruritus that requires intervention is the question.
Pruritus was intense and it was disturbing his sleep. So we proceeded with the suggestive of lymphoma, and before starting chemotherapy, oncologist wants to reduce the bilirubin level. So we proceeded with this ERCP.
So ERCP was done for decompression, mainly for the chemotherapy, no?
Chemotherapy.
Not really for the symptoms.
That's right.
That I think is fine. Niti, you'd like to comment on that?
Yeah. Because most of the oncologists want the jaundice to be cleared, and in this case there's an obstruction, so they want it to be cleared. So that is justifiable.
Sure. And
so long Hilar stricture was noted, and pixtail stent placed in the right duct. Left ductus could not candidate. So only right duct stenting done. And during ERCP, we took breast biopsy also, breast cytology, but it was not suggesting anything. Only biliary duct epithelium was there.
Yeah, but be careful when you're in the exam and all. Even if not only the exam, day-to-day practice, we would just manage the patient. If I were there, I would just ask for lymph node biopsy, and then if he has pruritus, the hemato-oncologist wants a decompression and reduction in the bilirubin, I'll go for a stenting and leave the patient alone and hand it over to them. That's it. The management. Okay. You agree to that, VT?
Yeah, definitely.
Yeah.
Just because we have advanced gadgets does not mean that we should be doing it. Okay. But in the examination, you should not even utter all those things. In most of the corporate hospitals, we may have to do all those things, but in examination, you have to follow the strict standard protocol. Okay. In this case, lymph node biopsy, consider lymphoma, some imaging, maybe maximum up to CT, and then ERCP to deal the obstructive jaundice.
Yeah, once it's matched to the bone, then in the CT also. Otherwise, for the CT, they want above the diaphragm, below the diaphragm for staging for lymphoma. So for that, they would ask for a CT. But once it's a bone mets, I think it's advanced, no? So then I think just hand it over to them for the management. And from our side, their help that we have to give them is to reduce the bilirubin. That's all that they need. They may be successful, they may not also be successful in stenting because it is a tight stricture. Okay, but here I think you succeeded and the bilirubin. So what is the patient on? Patient
given 6 cycles of R-CHOP, ma'am. Rituximab with R-CHOP. Now he's actually is normal, and his recent PET scan showing no metabolic lesions. Are almost all was metabolically inactive now.
That's the advance. That's a major this thing advance that has taken place. No?
And
that you
LFT
can get a good-
bilirubin came down to 0.6 and 0.2, and RPF was 77, AST, LT is 37 and 31.
So
in December
few take-home messages. Number one, other things apart from what we discussed, all the CHOP regimen, just see what that has an effect on the liver. Just see what are the drugs that can have an impact on the liver. Okay, all the anti-neoplastic regimen that is being used, not in this particular case, but otherwise in general, they do ask questions on the hepatotoxicity due to the medications that are given for some of these tumors. Then please know a little bit more of IHC. There may be examiners who are well versed with that. And then management of lymphoma in broad sense. That's what will be the regimen and what will be the follow-up and what will be the outcome in a patient like this. Understand? So therefore, in this particular patient, had this patient come to me for me that anorexia weight loss will be the takeoff. And based on that,
ma'am, we have to Dr. Harris there. What type of stent will you put? This is a malignant, extensive malignancy, no? So what type of stent you would put?
Sir, in this patient, our purpose is to reduce the bilirubin.
Okay.
So plastic stent will serve our purpose.
Yeah, because plastic stent, because it's I think it's a short term, no? Most probably once the chemotherapy sets in. Another important thing, is there any other treatment which are required for this patient other than chemotherapy and stenting? You have gone through all the investigation. There was some suggestion of hepatitis B. So patient with hepatitis B positive getting rituximab, is there any other thing you have to do? What would have been the correct approach?
We should make sure
HBsAg positive, then anti-HBs, then okay, HBV DNA, even if it is not done, it can, okay, you can do it. Then will you leave it like that or will you give any HBV therapy?
We have to start, sir, because we are going to give chemotherapy. And there is a chance.
Rituximab is something which is notorious to produce reactivation. That is another thing. So I think it has to be given. Standard antiviral therapy will have to be given. It doesn't matter whether HBV DNA is very low. In this situation, we don't bother about the low HBV DNA because what is going to happen is that there will be reactivation. Hepatitis B virus will be residing inside the cell. Okay, it will get reactivated, and the patient may even have fulminant hepatitis B, and that may even kill the patient. So, ideally, we should have treated the obstructive jaundice, started antiviral therapy, hepatitis B, and then proceeded with the chemotherapy for lymphoma.
Yeah, that because patient is going on rituximab. No? Yeah, I agree to that. Yeah. Because if it's a past, it can get reactivated. If it's a past infection, rituximab, it can get reactivated. The mononuclear cells may still be having the hepatitis B, no? The peripheral blood cells.
If it is non-rituximab, probably it was not that dangerous. But rituximab is, you have to give antiviral therapy. That is the standard now.
Exactly. I agree to that. Okay, can we take one or two questions from the chat box? Or can we have the other case?
There was a question right now. Anti-HBs titer present. What was the question?
Anti-HBs titer prevents reinfection, however, it doesn't protect from reactivation as it occurs from integrate. Agree. That's what we were telling. That even if there is even if it is a past infection, you can always get a reactivation. We agree to that, especially if the person is going on rituximab.
Yeah, we are artificially suppressing the immune status of the patient. Obviously, hepatitis B virus infection, even if anti-HBs is positive, it is quite possible that the virus is still lurking inside the hepatocyte. That is the assumption. Okay. Then
there's one question: how to palpate Sister Mary Joseph nodule? It will be hard nodule at the umbilicus. Okay, that is one.
Palpate the umbilicus.
Pruritus followed by jaundice favors for intrahepatic. Pruritus followed by jaundice need not be. Distal cholangiocarcinoma or Hilar cholangiocarcinoma can present as pruritus and then progress to jaundice. So pruritus per se does not tell you that it is intrahepatic. It can still be extrahepatic. Most of the time it will be extrahepatic only.
It is extrahepatic because viral hepatitis with cholestasis, jaundice comes first, followed by pruritus. In primary biliary cirrhosis, or even sclerosing cholangitis is the reverse. Pruritus first and jaundice much later. So that sort of thing.
I think the point is well taken. No, I missed on the rituximab. So rituximab, if the patient is on that regimen, you have to consider the possibility of anti-TNF plan for any patient with HbA negative antibodies. I don't know this question. What is it? Last question. Does he need antiviral?
Yeah, antiviral will definitely
Yes.
start. Yeah.
Anti-TNF, this not in context with this case, no? And let's not discuss hypothetical situations. Viti, we have the second case.
Yeah, it's
We'll ask Harish to take it up.
Srividya, can you stop sharing?
Short case. So I'll just give a brief history of this patient. This patient is a case of non-cirrhotic intrahepatic portal hypertension with recurrent bleed, and he has a TIPS in situ, and he's had several bandings done, okay, EVL, at least on I think 5-6 occasions in the past, and he came with. He just said he came one fine morning and he said that I'm not able to swallow saliva and I need to drink water. Okay, so what will be your approach in this patient? And he's a case with TIPS with recurrent HE manages and he's doing well for the last 3 years.
Unable to swallow saliva is kind of, we have to think of obstruction, esophageal obstruction.
So what is the grade of dysphagia? No, start discussing that first. So is it dysphagia or non-dysphagia?
It is dysphagia only.
Aphasia, or rather, not able to swallow even water, no?
So he's not able to swallow. He's not able to swallow anything, and he came actually to the outpatient clinic. So what should you do? Please don't answer in the chat box, sir. Yes. What will you do? Patient has come to the OP and he says, I'm not able to eat for the last 2 days. What questions would you ask the patient?
Onset of the dysphagia.
That's what I'm saying. It's acute, no?
Acute onset.
So what else would you ask? Ramya?
When exactly it happened, no? How exactly it happened? This patient most probably would have been having normal meals, and all of a sudden, if the patient is feeling dysphagia, you have to ask what is the exact event which actually precipitated it.
So what are the events that can precipitate? Come on, this question is a simple question. What will you ask? What is T-Cow syndrome?
Large bolus of solid.
The theory bit you know, but then when a patient comes to you and says, after last 2 days, I'm not able to swallow, what are the things that you would ask, doctor?
As told by sir, what is the event that precipitated?
What else would you ask? What are the events? What events would you ask? Patient did not come forward with the answers. So what direct questions would you ask the patient?
Is it associated with any pain?
What food item? What doctor? Come on. What questions will you ask to the patient?
What are the situations where patient will have acute dysphagia?
Yeah.
Painful, painless. This is a painless acute dysphagia.
Sir, impacted footballers.
Impacted footballers. Okay. Theory you always know. Okay, fine.
What type of footballers would you ask? What type of footballers would you ask? Mutton bowlers, chicken bowlers. That is how you ask the question. I spent 10 minutes to get the answer out of this patient. You understand? You have to ask what is it that precipitated. When else can a person come with acute dysphagia? So one is bolus impaction, number one. Number two?
Any foreign body ingestion.
Foreign body, such as?
Sometimes dentures.
Dentures, very good, yes. And then?
Or any coins in children usually.
Yeah, but not in this patient. Then what are the other causes of acute dysphagia? Or dinophagia is not there, but what are the other causes? Pills, no? If a person has an underlying, what are the causes? Can it be eosinophilic esophagitis? He says, actually, I'm having recurrent episodes, but this time it is all of a sudden. I've been managing, but this time I'm not able to swallow even water. He was walking up and down. He said, give me water. I want to swallow water. So your direct questions will be, when did it happen? So he said, 2 days back, I attended a marriage. and I had non-veg, and I took chicken. That's what he said. Okay. One other patient said, I took fish, and I asked, was there any bone in it? They said, no, the fish does not have bones. So then you need to know which are the fish which do not have bones in it. These were the direct questions that we posed to the patient. And then he said, and then over a period of time, within 1 or 2 days, he found that he could not even swallow saliva. So you have to grade the dysphagia. There can be no vomiting because it's totally obstructed. So what would you do? How would you manage this patient during the COVID time? The patient has a protocol, which is a COVID time. So, and the patient has come to you with the symptom. What would you do? Dr. BT, please take over the endoscopy.
Endoscopy has to be done in this patient.
How would you do, doctor? What would you keep ready? Come on, speak out. What would you keep ready? What are the things you keep ready? What are the things you expect during the procedure? What precautions would you take? What are the accessories that you would keep ready? Dr. BT, the endoscopy, but please take over.
There is a risk of aspiration in these patients, ma'am, because the patient is unprepared. So we have to protect the airway before the procedure.
In this patient, you would intubate and protect the airway. Huh? Patient is walking up and down and is just having this problem.
Patient is conscious and he doesn't have any other comorbidity and no neurological problems, no?
He's just walking up and down.
So, what will be, how will you proceed? Suppose you are seeing the patient, you are in the endoscopy room and you are supposed to do the procedure. What will you do?
What are the
you have to tell your
ready?
endoscopy assistants to keep certain gadgets, accessories ready, no?
Normally
in our,
if it is a bolus, I am suspecting.
Why can't you take it with the biopsy forceps? Because that is the one which is available in every endoscopy room at hand. Can you just remove it with the biopsy forceps?
Sir,
name all the foreign body forceps.
Yeah, biopsy forceps will cut through this.
Yes,
it is of no use. Even foreign body, the rat tooth, biopsy forceps will also cut through this. Because meat, it will, the biopsy forceps will cut through this. So you won't be able to.
It is ingested 2 days back.
Digested also.
Some part of digestion.
Decayed. Okay.
Forceps, we have alligator forceps, rat tooth forceps we have. Which can be used for
any snares or baskets.
Yeah, various snares are available. Then even dormia type baskets are available. Then nets, roth net type things. No, so these are the things with which you remove foreign body, especially in these affairs. Ma'am asked a question which you do not answer. Can a person with eosinophilic esophagus commit food impaction?
Yes.
Yes, no.
Yes, even in the absence of stricture, they may have. Another thing is that patients with the post-ESG, post-EVL, they may have a small stricture. This patient actually has got we find that ring there, no? That is actually a minor stricture there. Normally it will allow food, but when a big bolus comes, it will. So similarly, Sharsky ring, post-ESG stricture, post-EVL stricture, normally they may not have any dysphagia, but when a big bolus reaches there, they will have dysphagia, and it can be acute also, like this.
Secondly, this patient has had recurrent banding, so the possibility is there may be even varices when you're doing the procedure.
Yes.
Okay, the varices may also be there, so to be all the more careful. Then you don't, just like a shearing, like a portal cholangiopathy, you should not be shearing through the varix and pulling out the foreign body. Are you understanding? So all this should be there in your mind that when the procedure is being done, okay, I can expect varices may be there. Number 2, I can expect a stricture which may require dilatation. I may have to take out the bolus piecemeal and then see what is happening at the site of obstruction, and then take a call whether you need dilators. How critical is the lumen? At what lumen diameter of the esophagus do you get obstruction? All these questions they'll ask. They ask what is the AP diameter, what is the anterior posterior diameter, what is the side to side diameter. All these questions are asked in the exam, in the DND exam. And then at what stage will you get a dysphagia? And what will be the adequate amount that will allow a food bolus to pass through? So all these diameters, dimensions, all you should know. Okay, So now, so a Roth basket was passed, and then the patient was the foreign body was removed. It was actually a bolus impaction. There was chicken. It was a chicken bone that was present. So it's very important that you be very careful, especially when it's coming through the oropharynx. No, that's the place where it can get dislodged. So Roth basket is fairly a safe system, I suppose, that it doesn't happen. All these things don't happen. What will be the follow-up?
With large foreign bodies, the issue is once it crosses the trichopharynx, usually the patient will be sensitive and start gagging, coughing, etc. And unless you are careful, in a Rothnet it is no problem, but otherwise a piece of it may go to the trachea and then create more problems. So that way also one will have to be very careful. Okay, and when you remove the other type of foreign body like coins also, sometimes it will be difficult to negotiate the trichopharynx also. That's another thing. And I think the question of acute dysphagia, many people did not answer. Acute dysphagia, in the absence of a large bolus swallowing, neurological causes you will have to consider. So acute brainstem stroke and related things you have to consider. And is there any acute viral infection? But how does rabies present? It can also present with like acute difficulty in swallowing, no? Even though there will be other manifestations. So acute
Candidiasis.
neurological illnesses,
Yeah.
yeah. Then painful, like for example, pill esophagitis,
Esophagitis.
severe pain and difficulty in swallowing. So painful, acute painful dysphagia, acute painless dysphagia, plus or minus a prior food history of bolus producing the issue. So these all things will have to come into the your history taking, whether associated other neurological. Then whether there's a prior history of impaction, like a person with a stricture or eosinophilic esophagitis may have a prior history of impaction also. In spite of that, they may swallow. That's another thing. They may swallow big chunks of meat and all, and then have problems. So prior history of impaction, whether there's associated neurological phenomenon, whether it is painful, whether it was associated with the swallowing of a big bolus of meat. Okay, these all things will have to be
What will
kept
you
in.
advise the patient now?
Avoid large bolus.
What did you tell him? Masticate, no? Is to chew well. And you have to explain to him, draw the figure and tell him, this is what is happening to you. Anytime it can come as an acute problem, and to even mutton bolus and all, it has to be all minced into small pieces, and then only they should swallow all these things. Okay, other questions would be, can it be an acid peptic stricture? All these other questions will come out from this particular type of presentation. All right.
Yeah, even an early peptic stricture also,
yeah.
they may can have recurrent dysphagia due to even. In fact, we had a patient who got sclerotherapy and she had a very tiny hole only. The lumen was so much narrowed, but the patient was quite comfortable with. Maybe it was long-standing sort of stricture, and patient was comfortable. And one day she came with a severe dysphagia, and on endoscopy I found that actually a green piece has gone on obstructed that hole. And then until then she was fine. So some people are quite used to it. They don't complain of it, and sometimes come with the acute onset of food infection, even with a smaller object when they have a background stricture.
Because that piece, it swells. It swells,
yeah.
So when it swells, even in the small intestine, a small piece can also cause, it can cause edema and it can cause acute obstruction. And over a period of time after digestion takes place, it passes through. Okay. And just one last bit, the previous case, just remember that you have to check the HPV for the relatives and get them vaccinated. Just get the prevention, always get that into that. Just see that the family is checked, the previous case.
Yeah, I think the question by the examiner will be asking what else to do, what else to do, what else to do, like that. He won't give you any clue. So whenever you have a patient with HPV infection, you have to screen the family. Screen the family. It's very important.
Dr. Varghese, we can conclude.
Okay, I think this is an eye-opener case, because I would say, because if you what was initially the idea what we had initially, and the idea evolved after reanalyzing the history are totally different. Initially, I thought this is a straightforward case of hilar cholangiocarcinoma with the metastasis in the spine from the first few slides. But when ma'am started questioning that anorexia, weight loss, followed by pain, followed by jaundice, the sequential order in which things evolved. So you should have that sort of a thing in your mind. How the illness evolved over a period of time. That's another thing. Number two, you always have the advantage of a physical examination. That's in the real examination, you always have the advantage of the findings of physical examination. So you have to put the history and physical examination findings together, so that your list of differential diagnosis will be according to that, and therefore you have to sort of give prominence to certain history and perhaps underplay certain irrelevant distractors. That's also important.
Very
If you
important.
give so much importance to irrelevant distractors, the
Yeah.
examiners go totally in that direction, and you will be sort of put into great trouble. Okay, if things doesn't fit in, you don't sort of completely say no, but don't give so much importance like that. Okay,
Exactly.
so this is a situation where a systemic illness has presented to gastroenterology, and sometimes some of the examiners are quite knowledgeable about management of lymphoma, classification, all the IHT, immunohistochemistry, and all those stuff. So you have to be up to date regarding that, including revise your lymphoma staging and the current drug regime, the side effects of the regime, especially all the biologicals and other things, the chances of having delay, all those things you have to. And it's very important that you have to give antiviral therapy whenever rituximab is given in a patient with a lymphoma. That's very important.
And the last bit is the percentage of METs. Get that figure right out. Every organ and what is the risk of metastasis.
Yeah, that is, ma'am initially said,
That's very
especially
important.
GI tract, GI tract, you should know where all the mets occur. And for the liver, you should know, which is the most common primary CA which will produce liver metastasis, non-abdominal, non-GI, and like that, inside the abdomen. So I think refer and make a sort of list of these things and keep it ready.
And a
Okay.
list of all the generalized lymphadenopathy.
Yeah, generalized lymphadenopathy, the
Have
lymphadenopathy
a
with
list. Yeah.
hepatosplenomegaly,
Yeah.
these are standard thing. And some of your DNB examiners are very knowledgeable about hepatosplenomegaly and lymphadenopathy, and they will ask you everything about. It will be sort of a hematology discussion or a general medicine discussion, I would say. Okay, they will go back to general medicine level and start discussing. These are things not unknown to us, no? Because we all have gone through this general medicine exam pattern, and
Yeah.
lymphadenopathy, hepatosplenomegaly, differential diagnosis, all those things we have to be thorough. We cannot forget those things. Okay, these
They
are our
want,
foundations.
in fact, they want you to be thorough with general medicine, not with high specialty. They say general
And
medicine is not strong.
most of the examiners say that your fundamentals will have to be strong. Your
Exactly.
fundamental.
Yeah.
If you are making mistakes at fundamental levels, like
Yeah.
physical examination and ordinary things which you should know at MBBS or MD level, and you are making mistakes at that level, then it becomes less pardonable. Okay, if you make mistakes at DM level, which is an advanced things and all, they may just forget about. But basic things one must be very careful. Okay, this is my parting message.
Yeah, I think absolutely fine. And for the foreign body, this thing, just read all the accessories that you keep ready. When would you intubate? When would you not intubate? And situations where the person has varices, what is the prevalence of? Why should you get after EVL strictures? That's a very important question. Why should you get a stricture with EVL? When will it happen? So just read all this, no? That in EVL, where is the vessel that you're clipping?
We have
Very
not asked
important.
that question. Why
Yeah.
they developed stricture?
Stricture. Why do they develop
EST, it was
stricture?
very common. In
EST is
fact,
very common. Yeah.
we have. In fact, when I was doing DM, EST was just started, and we were
Yeah. Yeah.
practicing EST, and then
Yeah.
stricture was very common. Stricture was
Yeah.
almost invariably there.
Yeah.
But with the EVL, the advantage is that the stricture is very uncommon. But in spite of that, so a small sort of strictures can develop. Okay,
Yeah.
if you look carefully, you can find structure. If you do banding at same level, that's the thing. You have to do things for EST as well as EVL, slightly go up every time you put a band or EST injection, because then there won't be the same level which is producing stricture will not occur. Whatever ulcers will occur at different levels. Okay, vertically. Don't go and put the bands at the same level. That's it. Slightly up like that you have to do.
So most of the vessels are in the submucosal plane, no? But if you go a little deeper, then the chances of you picking up, that's the real worst situation. Otherwise, normally you should not get a stricture with just simple EVL, no? So they'll ask you about this. And then what happens from here on, they'll ask you where do you get the vessels? Varices are present in subepithelial, submucosal, then we go into that. The questions will go in that direction. To see that you know the anatomy of the varices with a figure. draw a figure and see where the vessels are placed in patients with esophageal varices. Okay, so that you know where do you inject. The questions will just take on from here. On the risk of stricture, would you like to dilate this? This patient does not require dilatation because it's fairly large. Only thing, tell him to modify the diet. All right. So Dr. Vijay has given a nice conclusion. I think we'll conclude the session. Thank you all. We'll meet next Thursday at 8:30. Dheeraj, you've seen the case? We'll take up that case next Thursday, okay? Dheeraj? I hope you've seen the case today, yeah. So we'll take up that case for discussion coming Thursday. All right?
The formal closing by Srividya.
Respected teachers and my dear colleagues, I am extremely thankful for Dr. Jayanti ma'am and Varghese sir for conducting an excellent session and guiding us thoroughly in all these topics. And I thank all presenters and discussants and who are joined in this session. And also I would like to thank Sun Sickness for giving us support. Thank you all once again.
Thank you. Thank you.
Okay, thank you. Good night.
Good night, VT. Good night.
Good night.
All the presenters did well. No, this thing, but just keep a watch on what we've discussed, all right?
Okay.
Okay.
Thank you.
Thank you.
Thank you. Bye.